So hello everyone, good evening, and today we are going to do the case presentation of the cataract. So you remember we have already done with the case of cataract with regards to the history we have already done, and last time we concluded with the patient who was 61-year-old female farmer. She was a known case of diabetes, presenting with the complaints of diminution of vision in the right eye 2 years back, and she had undergone the surgery in the left eye. Yes or no? We have already done this, and I know you people have started with your wards and you are facing the same things, that you are having the people having the gradual, painless, progressive diminution of vision. So we had discussed lot of the DDs also, what this patient can have. This patient can have the senile cataract, of course, that is the first thing. Then the patient can have the primary open angle glaucoma, diabetic retinopathy, we can have uncorrected refractive errors, and then we can also have the what you called as the dry RMD, gradual painless progressive pterygium can also be there. So we had discussed, and now we know that this patient might be having, because out of all the DDs, the most common one is obviously the senile cataract, and second to go is the primary open angle glaucoma. So now you have to go for examination. So keeping these things in mind, what is the examination that is actually expected out of you people, right? So you are ready. I hope you are done with the history we have already done with, and now we will be starting with the examination. So see, when we are discussing, when we are presenting a case of ophthalmology, this does not mean that we will go only with the ophthalmic examination, that we do not go only with the ocular examination. There are general guidelines that you always have to follow. So first you have to go with the general examination, and then you have to go with the ocular examination. And why this is doing? Because every organ is interconnected. We have got so many things which are having the manifestations in the eye, so obviously you have to check them. Then you have to see whether this patient is actually fit for the surgery or not. So that is the reason why we will always do first the general examination, and then we will go for the ocular examination. Just a quick check if my audio video is clear, guys. Anybody who can comment if my audio video is clear? Somebody can comment on my audio video. Yes. Okay. All right, Mahima. Thank you. Thank you, Vidya and Mahima. All right. So we will first start with the general examination. Now, if you go with the normal protocols of the general examination, that will be same. You are going to take the pulse rate. We are going to take the pulse rate. Thank you so much. Thank you. Thank you. So we are going with the pulse rate, and then we are also going with the respiratory rate. We are checking the blood pressure, and then we will look for so many things. What is the build of the patient? What is the height of the patient? What is the weight of the patient? And what is the BMI of the patient? Now, why actually we are interested? We want to know that if any of the systems is having any deficit in the patient, if the pulse is not okay, if the CVS is not okay, if the respiratory system is not okay, then we might get a problem in the anesthetic checkup, right? Anesthetic fitness. And you know that before going for the surgery, we require the fitness of the patient. We always require the pre-anesthetic checkup. Plus, when you are giving the local anesthetics will not be given in cases of arrhythmias. So that is the reason why we will be doing certain tests also, which will be pre-operative investigations, which are very, very important. Then so many times, when we are taking the blood pressure, and if the patient is having hypertension, then we will have to postpone. We have to postpone the OT, and we cannot do this OT because cataract is not life threatening, but if you are doing the surgery in these patients, then it can be life threatening. So you cannot carry out the cataract surgery in a patient who is not having a normal BP, who is not having a respiratory rate which is normal, or if the temperature is not normal. Even the temperature is important, because if the patient is having temperature, that can indicate the infection. And obviously I would not like to do a surgery during a infective stage of the patient, because at that time the immunity of the patient will be low. If the immunity will be low, more chances of infection, more chances of delayed wound healing. So again, the vitals are very important. Second important thing, why we are interested in the build of the patient, height, the BMI, because if you look for the causes of the cataract, okay, if you look at the causes of the cataract, one important thing is we can have the deficiency of the important nutrients. So if the patient is having the deficiency of the important nutrients, which is especially more common in the lower socioeconomic status, okay, we can be having the deficiency of the antioxidants. Then there will be deficiency of the antioxidants. Do you remember the antioxidative mechanism? See, these are the important Viva questions that you will be asked for when they are asking you these things. That why you are asking the BMI, why you are asking about the nutritional status of the patient, because I am interested whether or not he is taking proper amount of nutrients, because nutrients consists of antioxidants. We have got the beta carotenoids, so they will be asking you the antioxidative system. We have beta carotenoids, and we have vitamin B, vitamin C and vitamin E. These are the things that you require in the antioxidative mechanism. So if the patient is not taking the right amount of nutrients, he will not be having the antioxidative mechanism. Then he will not be having the cofactors for the enzymes, because you have got 3 enzymes. So you should know the names of 3 enzymes. You should know the names of the vitamins. Then what is the carrier of this vitamin C? Carrier is actually the MIP, myo-inositol phosphate, right? So these are the things. Then you have to find out all these things, whether the pallor is present or not. Why? Because why I'm interested in pallor, this patient may be having the anemia. Now this patient can be having the anemia, and due to the anemia there can be a deficiency of other nutrients also. So there is a possibility that other nutrients are also absent in this patient. Then I am interested in icterus. Why? Because icterus means the patient is having the jaundice. That means he is having some problem in the metabolism, right? So there can be things which are related to this. We can have the other systemic diseases which will include cataract also, as well as this jaundice also, any cyanosis, any clubbing, generalized lymphadenopathy. So you are going to do full head to toe examination. This is called as full head to toe examination. Now our patient is also a diabetic patient. Now because the patient is a diabetic patient, it is very, very important that will come under the test section, that I also do the HbA1c. This is very, very important, because maybe the blood sugar levels that you are doing that day are normal. Maybe the random blood sugar is also normal, fasting blood sugar is also normal, but we are interested in knowing the glucose levels that is present for the past 3 months. Actually that is going to tell me that how will this patient react to the wound healing. So I am interested in looking at the diabetic ulcers also, because if this patient is actually diabetic from a very long time, then the patient will definitely have the ulcers. It could be diabetic ulcers, it can be even the diabetic foot also. So any kind of ulcers with respect to the diabetes, if they are present in the patient, then that will show that the patient is having the uncontrolled diabetes. The blood sugar are deranged in this patient, that will definitely show. So this is very very important, that if your patient is having diabetes, and even if you are not suspecting the diabetic cataract, because you know in the diabetes even the pre-senile cataract is more common than the snowflake cataract. Now this is another question that they can ask, that yes, you are saying that your patient is having diabetes, now which cataract you are actually thinking of? So it is not that I am first thinking of the diabetic cataract, it is actually the pre-senile cataract only. So pre-senile cataract is actually more common than the snowflake cataract, but yes, there is a possibility that the patient can have the true metabolic cataract, and I definitely want to know what is the status of the diabetes. Is it deranged? For that you are going to look for the ulcers. So this is your examination. Then after this you have to do the systemic examination system wise. So you have to go, okay, so you have to go system by system. So first we are going for the CVS. CVS may look for the sounds S1, S2, there is some murmur or not. Then look in the respiratory system, bilateral air entry is equal or not, patient is having normal cranial nerves examination, conscious hai, well oriented hai. So basically I want to know that any neurological deficit is present or not in the patient. So basically I want to know the overall well-being of this patient. What is about the CVS, CNS, respi, all these systems are normal or not. Now another important thing are these three are very very important with respect to your eye examination. These three are very very important. I have to look for the head posture, I have to look for the facial symmetry also, as well as the forehead. Now take it one by one. Why the head posture is important? Now you know that this patient is having actually cataract, okay, but we have to think about the squint also, okay. This patient can be having squint also. So whenever we are actually looking for the head posture, always remember that whenever we are talking about the head posture of the patient, basically I have to look for three things. Number one is the head tilt. We have to look for the head tilt. Number two, we have to look for the face turn of the patient. And number three, the chin lift. We have to look for the chin lift. So what are the conditions where I can have head tilt? We know about the compensatory head tilts, है ना? Compensatory head tilt. So this compensatory head tilt takes place in the cases of superior oblique and the lateral rectus. You already know. So if this is a case, suppose it is having the associated palsies also, so superior oblique will show me the tilt on the opposite side, while lateral rectus will show the tilt on the same side. So basically more common is the obliques. Whenever we have the involvement of the obliques, we will have this head tilt. Second is your face turn. So face turn basically will take place in the cases of the horizontal extraocular muscles. Whenever the horizontal extraocular muscles are involved. Now what are your horizontal extraocular muscles? We will have medial rectus and the lateral rectus. While chin lift, so chin lift usually takes place in cases of the vertical extraocular muscles. This will take place in the cases of the vertical extraocular muscles. And a very very important thing, this takes place in the cases of the LPS palsy. So afterwards you will come to know that this is a case of a cataract and this was not there, but actually it's very important to rule out all these things, because maybe the cataract patient is having associated all these things. So all the things have to be rectified at the earliest. Now why I am having the chin lift? See, suppose the patient is having the LPS palsy and we are having ptosis. So obviously this patient will take the chin upward, chin lift will be there in order to clear that ptosis. So for that reason we will have the chin lift. Otherwise also if you have vertical muscles involved, then it will be your chin lift. So okay. So, Right. So we have done with this. Now another important thing is your facial symmetry. Why we are interested in taking the facial symmetry? Even the facial symmetry is important because this patient can be having the facial palsy. So these are the questions that will be asked from you guys when you are going ahead with the examination. What you are looking for the facial symmetry. So basically we are looking for the facial palsy. So if facial palsy is there, there are so many things. We will have drooping of the mouth, angle of the mouth, dribbling of the saliva is there. But what, we have absence of wrinkling of the forehead also. That is why we are looking at the forehead also. Deviation of the angle of mouth is there. But what you are looking for in the eye. So if I am having a facial palsy, what I will have the paralysis of orbicularis oculi muscle. Orbicularis oculi muscle. Now you know that this orbicularis oculi, which is present in the eye, this is supplied by the facial nerve. And what is the function? It is actually used to close the eye. Now if there is a palsy of this orbicularis oculi, the person will not be able to close the eye. So if the person is not able to close the eye, that will be called as the leg of Thelmos. So I have to look for the leg of Thelmos, whether leg of Thelmos is present in this patient or not. I will also have the exposure keratitis. I can also look for the exposure keratitis. Exposure keratitis means same. If the patient is not able to close the eye will be open up. So it is more exposed. So it is more exposed. I can have the exposure keratitis. Same can happen in cases of herpes zoster also when you have neuroparalytic keratitis. So this is the thing that you have to look. You have to look for the symmetry of the head posture also, the facial symmetry also. You have to look for the forehead also. Then you have to look for the ocular symmetry. You have to do this eye examination also. So what you have to do in this ocular examination, we have to do this HCRT test. This test is called as the Hirschberg corneal reflex test. Corneal reflex test. Hirschberg corneal reflex test we are doing. So what we are doing in this, suppose this is the eye and we are putting the light from a distance, right? So where you are going to see the reflex, that will show you that where what is the amount of squint. So if you are seeing this reflex exactly in the center, that means the patient is having the 0 degree squint. 0 degree squint, or I can say that there is no squint. If it is exactly in the center, then I will say it's a 0 degree squint or it's no squint. Then if it is present at the pupillary border, then this is your 15 degree squint. If it is present at the pupillary border, then that means the amount of squint is 15 degree. And if it is present anywhere in the limbus, that is means the patient is having the 45 degree squint. Then the patient is having 45 degree squint. If you are having anywhere in the center of this, so this will be your 45 minus 15. So this will be equal to the 30 degree squint. Then this will be equal to the 30 degree squint. So in the Hirschberg corneal reflex test, we are having a very simple test. Just put the torchlight test and see where the reflex is falling. So you will see a tiny reflex. If it is exactly in the center, that means we are having 0 degree squint. If you are having anywhere on the pupillary border, that is 15 degree. If you are having anywhere at the limbus, it is 45. And you are having anywhere in the center, then this is your 45 minus 15, 30 degree squint. So if you have understood this Hirschberg corneal reflex test, please let me know. You can be asked a question over this, and you can be asked as a short note also, right? So these are the things that you have to look for. Now if you have to present your ocular examination, so after taking the general examinations, we have to start with the ocular examination. In the ocular examination, right eye was having our cataract, that was having the diminution of vision, gradual, painless, progressive, and the left eye was the eye that was actually already had the surgery. So first you have to check is the visual acuity in this patient. See, why I want to know the visual acuity, I should know what is the amount of the diminution of vision that is actually present in the patient. That will help me in actually assessing what is type of cause is present in the patient. So first what I do is taking the visual acuity. Now how you will measure the visual acuity, that concept we already know, so I will not go into the details of that. For that we will do the Snellen's chart. Snellen's chart is the most commonly used visual acuity chart, but of course if your patient is illiterate, okay, if the patient is illiterate and you are not able to use the Snellen's chart, then you can use the E chart, or we are using the C chart. So in this case we are having a 61-year female who is a farmer. So if she is not able to read the Snellen's chart, I can go with the E chart or the Landau C chart. The broken ring test भी हम कर सकते हैं, any of this. Then there are certain methods by which we can actually predict the visual acuity after the surgery. So nowadays we have certain things by which I can have a rough estimate that what will be the amount of visual acuity in this person after the surgery. Yeah, yes. So this is there. This is your potential acuity meter. One is your potential acuity meter. This is one thing by which can you see this is written PM. So this is your potential acuity meter, which can actually predict the rough amount of visual acuity that we can have after this. And another important thing that you can use to predict the visual acuity afterwards is the laser interferometry. So these are the two important things if they ask you, because we will not go into the details of this. This is of PG level, but they can ask you the names. One is the potential acuity meter, another is the laser interferometry. These two things can be used to predict the amount of visual acuity, a rough estimate that a patient can have after the surgery. So first we are going to measure the visual acuity. I can have a rough estimate what will be the amount of visual acuity. Then what are the other things I should do? I can also go for the macular function test. Now why macular function test is important? Because if you are having a hazy media in a cataractous patient or you are having a clear media, before doing the surgery, I want to look at the macula also. Now, why looking at macula is important? Because I want to know what will be the prognosis of after the surgery. If my patient is having bad macula and I do the cataract surgery, I have not informed him. Informed consent is again very, very important, right? Then we might get into trouble. So, we will be discussing this macular function test also. See, there are two kind of macular function tests. Okay, so you should know that these two types are, one are with the clear media and one with the opaque media. So what are the macular function tests that I would like to do in a patient who is having a clear media, and what are the macular function tests I would like to do when the patient is having opaque media? So my patient most probably will be having opaque media because she is having cataract. So I would like to do this, but you should know both what are the macular function tests done. So pehla, if you look in the clear media, so you are already doing the visual acuity of the patient. So this is again very important. When you are taking the visual acuity in the patient, you are actually doing a macular function test. Then not only this, we also have to look for the contrast sensitivity, because in so many cases the patient is having glare, colored halo, so contrast sensitivity may be affected. Contrast sensitivity you can do with the help of the Pillai-Robson chart. So they may ask you the name of the chart. Pillai-Robson chart is there. For the visual acuity, we have got the Snellen's chart. And for the contrast sensitivity, we have this Pillai-Robson chart. Then the third important thing is your slit-lamp biomicroscopy. Now this is again very, very important, where you are using a 90D lens. Here we are using the that is we have the 90D lens you are using. You know, before going for the surgery, it is again very important that you look at the fundus also. Maybe fundus is having lot many problems. So even if you remove the cataract, the patient will not show you the enough response. So again, for a proper informed consent, it is very important to do the fundus examination. So for that, we are using slit-lamp biomicroscopy. Then we are doing the photo stress test. I will tell you about this also. Then a color vision. Now this is again very very important है ना. Simply you can do the visual acuity in the patient, you can do the color vision. Color vision के लिए most commonly which chart we are using is the Ishihara's chart. Ishihara's color plates. For this we are using the Ishihara color plate. So even if you are doing two things, you are easily managing your macular function test in the clear media. I can also use the Amsler grid test. Amsler grid test में grid of lines हैं. We have microperimetry. Then you have this FFA. This is your fundus fluorescein. Fundus fluorescein angiography. Fundus fluorescein angiography is there. And then number 9 is OCT, optical coherence. Optical coherence tomography. Optical coherence tomography. So I think out of these you know so many where actually we are doing this macular function test. FFA हम करते हैं for the vascular lesions. OCT we are doing for the retinal lesions. So you should know the list also. Now what is relevant in our patient? See, in our patient most probably we are having a case of the senile cataract. R is a opaque media. तो यहाँ पे what are the macular function tests we can do? We can do first of all the Maddox rod test. We can do the electroneurological test, that is electroretinography we can do. Number 3 पे what we can do is the visual evoked potential. Visual evoked potential we can do. Then number 4 पे what I told you, laser interferometry we can do, or the potential visual acuity meter. These are the two tests that can actually depict, or it can actually predict the visual acuity that we can have. We can predict the visual acuity afterwards. So this will be your number 5. Then number 6 will be having the entoptic phenomena, and number 7 is the B scan. So whole list of macular function test is again very very important. So after a while we will be coming back to this. अभी हम देखते हैं कि और other things that we need to do. So we have done this macular function test also, right? After the macular function test, we are coming to the IOP. Now intraocular pressure. Who will tell me the normal range of intraocular pressure? Anyone, guys? If you look at the so if you look at the intraocular pressure, see what happens when you are having a patient of cataract. We are thinking about the stages of cataract. Cortical, cortical cataract is more common. अब cortical cataract में first is the stage of the lamellar separation. First is the stage of the lamellar separation. Then second is your incipient cataract. Incipient cataract. Then number 3 is the immature senile cataract. Number 4 is the mature senile cataract. And number 5 is the hypermature senile cataract. Right. So, there is a stage in which we can have the rise in intraocular pressure, and what is this stage is the immature senile cataract. Now if you look here, what is happening in the immature senile cataract? Suppose this is the cornea, we have this iris, we have this lens, right? And this is the ciliary body. So aqueous humor is coming from this. It is coming from this ciliary body. It has to pass through this pupil. It is coming in this anterior chamber, something like this. Now in this case, we are going to have the swollen lens. So this can again be asked from you in the question, that why we can have the raised intraocular pressure and why I am interested in taking the intraocular pressure in this patient, because every stage of the cataract can lead to glaucoma. So I am interested in knowing whether or not this patient has gone into glaucoma, or there is a likelihood. So if this swollen lens is there, it can obstruct actually the quantity of aqueous humor which is going. So this stage will lead to a glaucoma. And what is the name of this glaucoma? It is actually the phacomorphic. This glaucoma is called as the phacomorphic glaucoma. This glaucoma is called as the phacomorphic glaucoma. Here you can have the swollen lens and you can also have the raised intraocular pressure. So this is again important, why we are interested in the raised intraocular pressure. Another important thing is that maybe this patient has gone into hypermature senile cataract. If this patient has gone into hypermature, then either we can have the Morganian cataract, or I can have the sclerotic type of hypermature type cataract. Okay, so again in these stages also we can have glaucoma, but what will be the names here? This will be the phacolytic glaucoma. Okay, and here we will have the phacotopic glaucoma. Okay, so because this is a practical session, so I'll not go in much of the theory part. So we already know that we can have different types of glaucoma in the different stages. Here also I can have raised intraocular pressure, phacomorphic maybe, phacolytic maybe I can have raised intraocular pressure, and phacotopic maybe I can have the raised intraocular pressure. So we are having the raised intraocular pressures in the different stages. That is why it is important. And who will tell me the normal range of intraocular pressure? Anybody who will tell me what is the normal range of intraocular pressure? And then they can also ask you about the different tonometers. So you should also be prepared for the answering different kind of tonometers, like the one which is most commonly used is the Schiot's. That will be the Schiot's indentation tonometer. And what is the gold standard? The gold standard is the Goldman's applanation tonometer. That will be called as the Goldman's applanation tonometer, right? We will be going into the details of this tonometer when we will be dealing with a case of glaucoma, and in my clinical videos I have shown you the full procedure also, how to measure the IOP by a Schiot's tonometer. So most commonly what we are using is the Schiot's indentation tonometer. In the gold standard we have got the Goldman's applanation tonometer. We'll be talking about its principle also, the Hirschberg law in a case of glaucoma, right? Okay, so we have done with this. Now another important thing that we are looking for after this IOP, okay, is your extraocular muscles. So how you are going to check your extraocular muscles? We have to look for all the extraocular muscles. For looking this, you have to check for the ocular movements. So for that you have to check for the ocular movements. Now how will you check the ocular movements in the patient? See this. Whenever we are talking about the ocular movements, always understand that we have got two kind of movements. One will be your uniocular movements, and second is the binocular. Uniocular movements and the binocular movements. Uniocular movements are actually the ductions, while if I talk about the binocular movements, then they are of two types. One is the versions and another is the vergences. So it's very important for you to check all these movements. See, ductions are uniocular movements. So ask the patient to look straight ahead, then straight up, straight down, straight right and straight left. These are your duction movements, right? So when you are doing movement only in one, so these ductions are according to the axis. So basically we are checking in the three axes we are doing. One is your horizontal axis, then one is the vertical axis, and another is the anteroposterior posterior axis. Now how to do this? Try to understand. Suppose this is your eyeball, okay? Now if I check the movement with respect to this horizontal axis, so with respect to this horizontal axis, it can go in elevation or depression. This is elevation or depression. So in the horizontal axis, I have to check the elevation and depression in the patient. Then in the vertical axis, like this, in the vertical axis, I have to check the adduction and abduction of the patient, something like this. So in the vertical, I have to check the adduction and the abduction. Okay, now don't confuse it with the plane of the movement. The plane of the movement is horizontal, but with respect to the vertical axis, on the third हो जाएगा ये वाला anteroposterior axis. So in the anteroposterior axis में क्या हो गया? It will be inward movement or it will be outward movement. So it will be intorsion or it will be extorsion. Intorsion or extorsion. So you have to check this. Then we have to check the conjugate movements in the patient, conjugate movements. And then you have to check the vergences. This is your disconjugate movement. So it is important that you are checking everything. Conjugate mein it can be dextroversion, it can be levoversion, supraversion, infraversion, dextro elevation, dextro depression, levo elevation, levo depression. Then vergences mein convergence and divergence. All the movements you have to see whether or not any of the extraocular muscle is involved or not. So you have to check for this. Then check for everything starting from the eyebrows hai, eyelashes hai, eyelids hai, conjunctiva mein you have to check. Now conjunctiva mein what you are going to check, if there is any edema is there or any congestion is there, any kind of abnormality. It can be a symblepharon, it can be any cyst, it can be blood, subconjunctival hemorrhage. So look for any other abnormality, because if you are having any history of trauma, you can have subconjunctival hemorrhages, any history of conjunctivitis, because if the patient is having any discharge, any redness, any congestion, then I will not go for the cataract surgery. Similarly, the cornea and the limbus. Now I am very interested in the cornea and the limbus. Now why I am interested in cornea and limbus? Because we have got two refractive organs, है ना? So these give me four refractive surfaces. That is anterior surface of cornea, posterior surface of cornea, anterior surface of lens, and then we have the posterior surface of lens. Now lens is already opacified, so we are not having these surfaces. Obviously we are concerned with the cornea. If I am replacing the lens but I am not having the clear cornea, then obviously I am not going to give the vision to the patient. So you have to look beforehand ki what is the size, microcornea hai, megalocornea hai, corneal clouding, corneal edema, corneal opacity, corneal blood staining, anything, corneal erosion, corneal ulcers can be there, it can be an infective case. And especially I am interested in the limbus. Why? Because actually I have to give the incision at the limbus, because the incision actually has to be given at the limbus. So if my limbal area is not clear, where I will give the incision? And all the cataract surgeries are actually having the incision at the level of limbus only. So it's very important that when you are doing the examination, look at the limbus of the patient so that we have a clear area for giving the incision. So this is the thing. Then another important thing that you have to look for is the anterior chamber. What are the things you have to see? What is the depth of anterior chamber? What are the contents of anterior chamber? So normally anterior chamber should be quiet, but we can have certain, abnormal contents in the anterior chamber. What are these abnormal contents? I can have the hyphema. Hyphema means we can have blood in anterior chamber, or we can have hypopaeon. That is, we can have the pus in the anterior chamber. I can have hyphema also, that is your blood in anterior chamber. I can have a pus, that is your exudates in the anterior chamber can be there. Any inflammatory cells are there. Look for all these things. And very important, how to assess the depth of anterior chamber. So what you have to do is that you have to show the light from the side. When you are showing the light from the side, can you see from the middle side we are showing? So if you are showing the light from this side, and if whole of the iris is illuminated, so if whole of the iris is illuminated, that means your anterior chamber is normal. But if it is very very shallow, what you are going to have, you are not able to see this area. ठीक है ना, this area is dark, so that means the shadow is there. That means the anterior chamber is shallow. Now why I am interested in shallow anterior chamber? Obviously when I am doing the cataract surgery and anterior chamber is shallow, the chances of complications will be very very high. Plus the other thing is that when we are having the shallow anterior chamber, the chances of the glaucoma related complications will be again very very high in this patient. Now one other way how you can compare this anterior chamber depth, how can you see this anterior chamber depth? There, for that you can do the Van Harrich's grading. For that we can do the Van Harrich's grading. So this is actually done over the slit lamp Van Harrich grading, where you are actually comparing the depth of anterior chamber with the corneal thickness. So what we are doing, if you are comparing it, so we can start from the grade 4. So if it is more than the corneal thickness, then angle is wide open, not a problem. So we'll make 2 slits, one for the anterior chamber and one for the corneal thickness. So if it is more than the corneal thickness, I will say it is open. But if it is 1/4 to half only, so it is 1/4 to half, then it is going to open. But if it is 1/4, means equal to 1/4, then it is narrow. If it is less than 1/4, then it becomes very very narrow and then extremely closed. So this is how over the slit lamp we can compare the depth of anterior chamber with the corneal thickness also. That is also one way of doing the things. So you have to check for the anterior chamber depth. Then look for the pupil. Pupil is again very very important, because pupil is acting as a window to your optic nerve and the retina. If you are having any abnormal pupillary reactions, then you will come to know that the optic nerve is intact or not. Look for any abnormal pupillary reactions. It can be the Argel Robertson pupil we can have, or we can have the Adie's tonic pupil, that can be there, or we can have the RAPD as a earliest indication of the optic nerve disease. So look for any accessory pupils, abnormal color of the pupil, abnormal pupillary reactions. Look for the normal direct light reflex also, indirect light reflex also. Look for the accommodation reflex. All these things you have to check. And then a very important thing, you come to the lens. Now lens may if you are getting the cataract, okay, then what you have to check, what is the stage of cataract. So what is the color of the cataract that you are going to have. Here I wrote all the stages of the cataract. So what were the colors here? In cases of immature cataract, we were having the grayish color. Then in the mature senile cataract, it becomes pearly white in color. And in cases of the hypermature cataract, it becomes chalky white in color. Then it becomes the chalky white in color. So you will have to see whether or not we have iris shadow and what is the color. So we will be discussing the concept of iris shadow also, and before that you also have to look for the color. That will give me insight that whether this cataract is an immature cataract, or it's a mature cataract, or it's a hypermature cataract, right? And then obviously you will have to look for the iris shadow. Now see, this is the concept of iris shadow. Can you see this shadow of the iris here falling? This is your iris shadow. So because this is the iris shadow here present. Now because this is the iris shadow present, therefore I will say it's a immature senile cataract. Because what happens in the immature cataract, suppose this is the cornea here, and this is the iris, and then this is the lens here. Okay? Now if I have opacity which is still lesser than the whole size of the cataract, we are still having the clear cortex and we are having this cataract here in the center. So this cataract is actually the immature senile cataract. Now whenever I am showing the light, which is the oblique light, this is the oblique light. Okay, whenever you want to see the shadow, we have to use the oblique light. Now it is passing through this pupillary margin and it is coming to this. So this shadow of the iris will be formed over this area. Here this shadow will be formed because still we are having this clear cortex. So if I am not having any clear cortex, then no shadow will be formed. So it's very, very important that you see that whether this iris shadow is present or not. So in our patient it is present, and iris shadow present means that it's a case of immature senile cataract, because whenever you are having a mature senile cataract, that means you are not having the clear cortex, you will never get a iris shadow. And then finally we have to look for the fundus. So fundus में वैसे तो opaque media है, तो opaque media में it gets little tiresome to see the fundus, but we still try to see the optic disc, the macula, the vessels, and if at all it's very, very opaque and you are not able to see anything. In our case we were able to see because it's a case of immature senile cataract. But if I have the total ripe cataract, the mature senile cataract, and I'm not able to see anything, then actually we should go for the B-scan ultrasound, because you never know what is going behind. So it's very, very important that you do the B-scan ultrasound to rule out any abnormalities. Okay. Then another important thing is we should also do the Roplast test, regurgitation, when you are applying the pressure over this lacrimal sac, over the sac area, because it's very, very important to rule out the dacryocystitis. It is very, very important that you rule out the dacryocystitis. If I am having infection, okay, the active case of infection will never be taken for the cataract surgery, because always there is a risk of the bacterial endophthalmitis, and that is the most serious complication of the cataract surgery. Bacterial endophthalmitis, we will have the risk of the bacterial endophthalmitis. So whenever we have the dacryocystitis, we have a risk of the bacterial endophthalmitis, and therefore the active source of infection should not be taken for the cataract surgery. So in our patient we were having this iris shadow, right? While if you look at the other eye, so what is happening, if I see my patient, when we did the slit lamp examination, what kind of presentation was there? In the right eye we were having the iris shadow. So because in the right eye we were having the iris shadow, we were having the grayish white color of the cataract, and we were having the lens opacity. So we made this provisional diagnosis that this patient is having the right eye immature senile cataract, while in the left eye we are getting the shimmering reflex. Then we are getting a shimmering reflex, and we are having already history of surgery was also present. Therefore this is a case of the pseudophakia. We had a history of the cataract. Another important thing is that when you check for the anterior chamber, I told you that in cases of immature senile cataract you will have the shallow anterior chamber. You will have this shallow anterior chamber because you are having the swollen lens, right? While if you compare it with the other eye was having the pseudophakia. Pseudophakia mein you will have the deep anterior chamber. Why? Because here you are having artificial lens, and artificial lens is very, very thin. Jabki if you compare the normal thin lens, jo normal lens hoga, that thickness is much more, that is about 3.5 to 5 mm. That is why when you actually compare the anterior chamber depth in the pseudophakic people or the aphakic people compared to the normal one, they have much deeper. Aphakia mein to obviously it will be much more. So that is the depth of anterior chamber. Fundus examination, I have told you that it is important because we have to rule out certain things, especially we have the ARMD. Maybe this patient is more than 60 years of age, so maybe the patient is having the features of the age related macular degeneration could be there, can be having the features of diabetic retinopathy, can be having the retinal detachment, or we can have the vitreous degeneration. These are the common things which can be having, maybe some retinal hole, maybe some retinal degenerations that is going to affect the final visual prognosis in the patient, and that is the reason that it is of utmost importance. Without doing the fundus examination, we will never do the cataract surgery. So that is very, very important. So we will have a look about here on the different types of the cataract that we can have in the patient. Can you see here you are having this wedge shaped opacities in the periphery. So this is basically the cuneiform variety of the cataract, which is the most common cortical cataract. Cuneiform variety of the cortical cataract, that is there. While if you look here you are having the opacity in the center. See, this is a slit lamp section. This anterior area is your cornea, right? And this biconvex area will be the lens. This is the lens here. So central area is having the nuclear sclerosis. This area is having nuclear sclerosis like this. Then this is your grayish. So this is your case of immature senile cataract, while this is a beautiful pearly white, hai na? So this is a case of mature senile cataract. Can you see? We are having the different stages of the cataract as they are seeing on the slit lamp. Factor which increases the IOP. I could not get your question fully, Kumar Gaurav. Which factor and where? Okay, thoda sa more specify your answer than question, then I'll answer you. Then see this. We can also have the hypermature senile cataract. So hypermature mein this is nucleus settling at the bottom. So this is your Morganian type, while this is a plaque-like area in the center. So this is your posterior subcapsular cataract. So this we have done in the image-based sessions also. Chalky white color is your hypermature cataract, grayish white is immature cataract, pearly white is mature cataract, right? So these are the different kinds of cataract. So we can say, means because we have already made a provisional diagnosis of the patient ki right eye mein immature senile cataract and the left eye has already gone the surgery. So he has undergone maybe the cataract surgery. So now we are coming, because with the help of examination you try to actually make sure that whatever history you have taken, whatever information you have gathered, you try to actually rationalize and prove that yes, these things are right. So we are coming to the thing that yes, right eye is having the immature senile cataract. We have seen the iris shadow also, the color of the cataract also, and the left eye is having the cataract surgery. So this is your pseudophakia. Now what are the other things that we can keep in DD? So I told you we can keep diabetic retinopathy. We have history of diabetes, hypertension, retinopathy. Glaucoma may it will be the primary open angle glaucoma that we will keep, right? Because gradual painless progressive hai, ARMD hai. So out of these, I think hypertension is not that common, because hypertension retinopathy is not that commonly causing the diminution of vision, but certainly diabetic retinopathy is very common. Primary open angle glaucoma ho sakta hai, ARMD ho sakta hai. So this you can actually rule out on the fundus examination. We had done the fundus examination. So if I am doing the fundus examination, I am getting the microaneurysms, then I am getting dots and the blots, then I am getting the hard exudates. Then basically you are thinking about the diabetic retinopathy. Open angle glaucoma mein I should get the triad. Then you will think about the primary open angle glaucoma. That means you should have the raised intraocular pressure, you should have the optic disc changes, and third is the visual field defect. So how will you come to know? Because you have already done with the IOP. ठीक है ना? Optic disc changes you will get on the slit lamp biomicroscopy. Visual field defects, this will be done by the perimetry. So all these tests have to be done before going for the cataract surgery. ERMD may you have to look for the drusense, because you know it is the dry ERMD which is causing the gradual painless progressive diminution of vision. So if you are thinking about ERMD, so that has to be a dry ERMD. For that, the characteristic lesion is drusense that you can actually rule out on fundus. So once you have done with the ruling out, now what are the laboratory investigations? So basically we have made the diagnosis that this patient is having immature senile cataract and you have to go with the cataract surgery. So what are the investigations? What are the serological investigations that you should give to this patient? So very important, first is the hemogram. You have to do the hemogram. Now whenever you are doing any surgery, the first important thing is the hemoglobin along with the ESR, because we will not do the test in cases of anemia or the ESR is high, some infection is there. Second important thing is your blood sugar. Very important, blood sugar, because we have to rule out the diabetes, है ना? And as I told you, because the patient is having the diabetes, she is a known case of diabetes, it's very important that you do the HbA1c. Especially important is HbA1c, because I want to know the status of the sugar from the last 3 months. So not only 1 month is important, I am interested in knowing the blood sugar level from the last 3 months. Then you have to do the urine analysis, routine and microscopy, and if you are getting any pus cells, that means there can be infection, then you have to go for the urine culture. These are the routine things that we have to do. Look for the chest x-ray also. Chest x-ray, again, we are not doing in every case, but we can do this chest x-ray in order to rule out any foci of the infection. Any foci of infection, we can also do the chest x-ray. Syringing may we are doing the Roplast test to rule out the cases of the dicryocystitis for any infection. Conjunctival swab bhi le sakte hai if we are suspecting any conjunctivitis. If you are suspecting any conjunctivitis, then we have to do this. Then very important is blood pressure. Blood pressure as a part of vitals bhi kiya tha humne. And blood pressure we are doing just before doing the cataract surgery, the laboratory investigations, because we can omit any of the tests, but 3 tests we are always doing. Ek to this blood sugar we are always doing, the blood pressure we are always doing, and this ECG. 3 things we are always doing, because if you are operating the patient under high pressures, that could be really dangerous. If you are doing the patient surgery when he is having the cardiac arrhythmias and you have to give the blocks, local anesthetics, that could be really dangerous. And if the blood sugar levels are deranged, then again it is very dangerous, because the patient's elevated sugar levels can interrupt with the quality of the wound healing and everything. So don't omit these 3 things under any reason, right? Then we are also worried about this oculocardiac reflex. What happens when you are applying the traction? See, when we are doing the cataract surgery, we apply a bridle suture here. So bridle suture in the superior rectus muscle, and we are raising it because I want a clear area to be given where I can give the limbal incision. So there is sometimes what is happening, there is a decrease in the pulse rate when I am applying this traction on the extraocular muscles. So there is actually the risk of this oculocardiac reflex also. That is also one reason why I am interested in doing the ECG. Alright. So yeah. So finally we come to the management. Once a diagnosis is made that my patient is having the right eye ka immature senile cataract, and left eye mein she has already done, so she was having the pseudophakia. So we know that still now we are not having any medical treatment available, so the treatment of choice is actually surgery. So what is the surgical options we have to do? It is the cataract surgery with the PCIOL implantation. So what we have to actually offer to this patient is the cataract extraction we have to do along with the PCIOL implantation. So when you do the cataract surgery, what we are doing, we are creating the aphakia, matlab absence of the lenses there. And if I am removing the lens, the person will become hypermetropic. then this person is becoming hypermetropic because total power of the eye is 60 diopters, जिसमें से cornea will be 43 to 45. This is cornea, and the lens is actually 15 to 17 diopter. This is your lens. So if I am removing this lens, I am reducing the power of the eye, and if I am reducing the power of the eye, the patient is becoming hypermetropic. So I will have to replace it with the artificial lens so that this patient becomes pseudophakic. Therefore, this patient becomes pseudophakic. So from aphakia, we are creating pseudophakia by giving this artificial lens. This is your posterior chamber. Posterior chamber intraocular lens implantation. Posterior chamber intraocular lens implantation. Now we have different kind of surgeries that we can do. Okay, we can do ICCE, we can do ECCE, then we can do the SICS, and then number 4 is the phacoemulsification. So these are the 4 major type of surgeries that we can do. That means I can actually do the intracapsular cataract surgery also. We can do extracapsular cataract surgery also. So basically the difference is while you are leaving the posterior capsule or you are removing it. So we are keeping in this because in the extracapsular cataract extraction I am keeping this posterior capsule over which I can actually implant my IUL. So this is actually done nowadays. The only indication of ICCA is the subluxation of the lens. Only indication of ICCE nowadays is the subluxation, otherwise we are not doing it. So in ICCE, the incision size is also very large. It is 10 to 12 mm. So what we are doing nowadays is ECCE, where we have 7 to 8 mm, and we are actually leaving this posterior capsule also over which I can implant my IOL, right? Then SICS is a small incision cataract surgery. Small incision cataract surgery, where even you are giving much smaller incision. It is 5 to 7 mm. So basically my purpose is that we are going towards the suture-less surgeries. And finally the most advanced is the phacoemulsification, where you are doing between 3 to 3.5 mm only. So we can give the different choices to the patient, and whatever the patient is affordable and comfortable in, we can give phacoemulsification. And then finally, that is the most advanced thing, we can also have the flex. This is actually the femtosecond laser assisted cataract surgery. So these surgeries were actually sutureless surgeries. The good thing about flex is that this is not only sutureless, but it is also bladeless and the sutureless. Bladeless as well as the sutureless surgery. So this is the whole range of history of cataract surgery, the examination, what is the relevant examination, why you are doing it, what are the related viva questions that could be asked, and finally what is the management profile that we can actually provide to this patient. So if there is any question, guys, you can put up your questions. So I hope you understood, and this is the very, very important topic. I think cataract is the first thing that is actually asked whenever you are going to your ward leaves and your vivas. So I hope the thing is clear, and if you have any questions, any queries, guys, keep on commenting on the comment section of this video. I'll keep on answering, and definitely again we'll meet with another interesting and very important case of eye next time. Thank you and happy ophthalmology.